Thank you very much, Samin, for this introduction, and I appreciate to be here. I see more and more people every year. Means what you are doing is a success. Well, thank you very much for inviting me this morning. The title of my presentation is Global Perspective of Cardiovascular Health. What that means is there is a significant trend today on economic basis to move from very expensive end of life and disease towards earlier and earlier to identify people who are at risk and to promote health. I'm going to take a piece of this, and I'm going to focus this morning about our data on 12,000 people using three-dimensional vascular ultrasound. I don't say intravascular, it's vascular, so it's non-invasive. And I will present to you the data for the first time on a number of issues that were not presented before. In the slide that is here, what you have is, when we talk about health, we may talk about people between age 50 and 100 with a number of challenges. We may talk about people between age 25 and 50, which is the focus today, or we may talk about people between birth and age 25. When we talk about preventing cardiovascular disease, it's very important scientifically and educationally to divide the population in three different ages, because it's completely different, the educational tools and the science behind it. We have 12,000 patients with three different studies, and actually what is interesting, the studies have been very consistent. Consistent in what? In the feasibility of the studies, the 2D and 3D ultrasound, in the prediction of the progression of plaques and events, in the preventive aspects related to lipids, and then we have to talk about the future of such technologies that are coming up very quickly. Now let me start with the first study. This is a study, the HRP high-risk plaque. This study actually involved 6,000 people, never had cardiovascular disease in the area of Florida and Chicago. And we use two technologies. Here is the 2D technology. Basically, is you use the probe for carotid disease that is very much focused on intimal medial thickening. You move up, and then you can get a bidimensional approach of the whole carotid artery. The problem is the speed that you move the device may change a little bit, and therefore you cannot quantify accurately the cubic millimeters of disease or burden of disease of the carotids. Something that can be done, as I will show you in a moment, with a device that is fixed, and actually the movement is very, very stable. Then you can say, what is the burden of disease? How many cubic millimeters of disease is of atherosclerosis? And we do this in the carotids, in the femoral, and in the aorta. We quantify how much disease is absolutely non-invasively. And here's classification of the coronary arteries. This is the mobile unit that we use for classification and also for 3D ultrasound, very feasible. And here we are beginning now to provide results. What we look is at the burden of disease in the carotid artery, focal disease, the maximal intimal thickening, and then we look at the maximal thickening of the focal lesion and intimal medial thickening. As you will see in a moment, intimal medial thickening doesn't provide any information at all, very little compared with focal disease, the burden of disease or the thickening of the focal lesion. And this is beginning to provide data. This is actually Framingham, low risk, intermediate risk, and high risk. And these actually are the tertials. The blue means mild to moderate disease, moderate to significant is in red, and more than significant, rather very extensive burden of disease is in black. And as you see, as you increase in Framingham, we see more and more disease in the carotid system by 3D ultrasound. Then what we have here is the combination of 2D ultrasound, I'm sorry, in this particular study, and calcification of the coronary arteries. And more focal disease, more and more calcification, higher you really improve the score versus Framingham. In fact, this is MACE, which includes also revascularization and intervention, as I'm saying. But here's the primary endpoints, which is about the stroke myocardial infarction and cardiovascular death. And the fact is, at 3 to 4 years of follow-up, we have 82 events, and this reclassified actually Framingham by about more than 25%. That is, Framingham is a predictor at a long term, but here we are dealing with people who have a burden of disease, and therefore we are biased. This is the highest risk factor. The disease is evolving. That's the advantage of this technology. Where Framingham, from 100 smokers, 50 will develop myocardial infarction and 50 will not. So you can never tell. Here is just, you're really already outlining who is in trouble. Then comes the issue of lipids, and it's interesting, but before I go into this is, the question is, how many patients following the guidelines of ACC, AHA that we did, the individuals that we screen, would have to be on lipid, on statins, 86%. But we had many patients with 0 calcium score and no focal disease in the carotid arteries. So the final result is, by using this technology, they were not eligible, before this technology, not eligible for statins in this population following the guidelines, where if you look at the imaging, much significant number of people should not be treated with the statins because there is no disease at all. So that's one of the advantages of this. Now we have a very interesting aspect, perhaps the most interesting. This was published in the New England Journal in December, which is the combination of 4 studies, including ours, very similar, 55,000 participants. What we did is we looked at the blood that we took from all these patients that we did imaging, and the blood we look at 50 genes that we know can predict or can be involved in coronary disease. And then we classify by the number of mutations of these 50 genes who was at a high genetic score. And at the same time, we look at the 7 conventional risk factors. And the question is, what is more important, the risk factor profile in coronary disease or the genetics? The results were surprising, completely separated. And that is, except for diabetes type 1 and familial hypercholesterolemia, there is no relationship between the risk factor profile and actually the genetic profile. These are people with a high genetic score. These are the events. These are people with a high risk factor score. These are the events. There is no connection. The most important finding, however, was that in people on high score, if they took care of the risk factors, the events decreased by 50%. There are no people without risk factors. So to have a high genetic score, it doesn't justify saying, I don't care because I'm in trouble. You are not, if you really take care of the risk factors. Only 1% of the population are free of the 7 risk factors. Only 1% in this country. Is interesting. But the most interesting paper is coming out also in the New England Journal in the next few weeks. Of all the genes, we found one very critical, Tet2 of the macrophage. Why is important? Because as the disease evolves and lipid deposition takes place, the monocytes come in, and actually they are healers, the monocyte type 2, with connective tissue synthesis. And this is a plaque that grows very slowly, small clot, and it grows, and it's very silent. On the other hand, about 1% of the ruptures probably is this blood clot, and the macrophage that takes care is very, very devastating. It's macrophages type 1, which actually what they do, they destroy all the system that is really with metalloproteinases and so forth. And what is fascinating is that Tet2, if it is mutated, really leads to a very aggressive macrophage or monocyte, which may explain the importance of the genetics in this disease. And it's fascinating. Anyway, this paper is coming out very soon. So this came all from imaging technology. And now what we are doing, in September, we'll know the follow-up not of 3 years, but we'll know the follow-up of 8 years of the study that I just presented. And I think it's fascinating because we are following all these 6,000 people with non-invasive technology as I am presenting. And this leads to the second study, which is the PESA study. The problem with the first study I presented is these people were actually an average age of 65, 70. And when we showed in some of them the information that they were having significant disease, the answer was, I don't care. Let me tell you the reality here. The reality is we are in a world that we don't feel vulnerable. If we feel well, nothing happens. And even if you show the arteries to these people, it doesn't work. My theory is that young people will react differently. So we moved the same study to 4,000 people much younger in Spain. Exactly what I presented to you. And now I will show you the data, which is fascinating. This is the PESA study. Here we did 3D ultrasound. And I just want to say to you, the equipment is here, and the rotor goes slowly with the same velocity. Now you quantify by cubic millimeters how much disease is in the iliofemoral, in the carotids, etc. The first thing is the following. Let's see women age 50. 50% already have 3, 4, 5, or 6 regions with focal disease. 2 carotids, 2 iliofemorals, aorta, or calcification of the coronary arteries. In a 50-year-old man, 2/3 have already significant disease in about 3, 4, or 5 regions. So as the pathologist told us many years ago, this is a disease that appears early in life, but we have forgotten about it. And now with imaging technology, we are beginning to understand again, or to begin to think again of a process that is quite devastating. Now this is a critical slide. It's the iliofemoral region. It's much more sensitive than the carotid. So if you want to know somebody, if the disease is beginning, go to the iliofemoral region. This is actually, you can see, this is always iliofemoral, what you see in blue, and this is the people who had disease in the carotids. You see, men and women. And we have seen this in all the studies. So I see a tremendous future with 3D ultrasound of the iliofemoral region, because this disease is very extensive, it's systemic, as we see in all our people. So it starts in one place and moves very rapidly. And it's interesting, in the iliofemoral region is in blue versus the carotid is in red. You can see, for example, dyslipidemia, smoking, how much it affects the legs. More than the carotid arteries. It's just to give you a sense that now we have in 12,000 people what risk factors affect more one region versus the other. I'm not going to spend the time to give you this, but we have a very interesting information about the several risk factors. And now this is not surprising. What we found is that a number of people with low risk for Framingham had significant disease subclinically. In red is generalized 4 to 6 sites, 2 to 3 is actually, these are the genetic people. So it's very interesting that to say, you know, I have no risk factors, I feel perfect, I'm not sure you are so perfect, because we are seeing now disease when the risk factor profile is actually low. This is following the Framingham 10 years, this is Framingham 30 years. And this is with the European guidelines. It's exactly the same thing. So what we found is that no risk factors doesn't mean you are free of disease. And this is actually what we are seeing from the non-invasive point of view. And here is the other side of the statins. I told you before that we find a number of people that by imaging, we don't see any disease, but by guidelines, they should be on statins. Here we see also the opposite. There are people who would not take statins according to guidelines, but we already have some significant disease. What I'm telling you, the future is moving to a subclinical disease, people which can begin to quantify things, who is really in trouble, who is not. And this is now the study, the PESA study is continuing now. We didn't have events because we're young people. Now we are entering into this phase. It's a 20-year study. And we are now moving into these 4,000 people into the stage that they are beginning to have events. The study in General Motors, which is 2,000 workers, actually was fascinating, but showed everything I presented to you. Here is, for example, in red is a lot of disease, less disease, but you can see that low risk for Framingham, moderate risk, high risk means if you are very low risk of Framingham, you are not free of disease. We found this in the study with the General Motors. And here you can see the femoral versus carotids in all the groups. All of this is always femoral versus carotids is less. And now, very important piece of information. We are very involved with developing countries, and you know, these tests of blood, cholesterol are very, very expensive. So we did a study in the group that I presented of 2,000. We took the 7 risk factors in one group, and the other we didn't take blood sugar and blood cholesterol. And the question is, what is the predictability of the disease using 5 risk factors with no blood versus 7 risk factors? Exactly the same. I don't have to go into, this is going to be published now. I don't want to go into the colors, but if you look the top and the bottom, these are 5 risk factors. This is 7. Everything low, high risk, intermediate, or low risk, and this is the degree of disease, is exactly the same. So what happens is obesity goes to hypertension and high cholesterol and diabetes. So when you really look at all of these, just diabetes by itself and high cholesterol do not add much to the point of the 5 risk factors that you can get in your practice in 10 minutes. That's the difference. And then here is the combination where we are going, according to this study with General Motors, is a combination. Here we have calcium, calcification, 3D ultrasound, and then the Framingham or the European. And I don't have to go into the details, but it's like a formula that you may be predicting. Here's the question. And so what? Are you going to change lifestyle if I show you everything I presented here? They do if you are young. And that's what we have found in the younger people in Spain. All those 4,000 people are now randomized into behavior. What kind of behavior? And now it gets into the issue of community. And just let me give you the answer. We adults do not change unless we are with somebody else or with a community. And that's a critical concept. We don't change individually. And we have a lot of data, but actually to present the two, one is a study we did with Rajesh Vedananthan in Kenya, poor country where we work, high blood pressure because they don't have freezers. They keep the food with salt and they develop hypertension and strokes. We distribute automatic blood pressure machines to the people in the streets. They took the blood pressure of the neighbors of other neighbors. It's incredible, a huge motivation. And these blood pressures are registered in intelligent phones. It's all centralized, no cost. It's fascinating. This is one way that we are now using on communities with specific risk factors in Madrid. And the other is actually Alcohol Anonymous. We started in the island of Grenada, then we went into the town of my wife in Spain, and then in 7 communities in Spain. And basically the concept is people, they get together, groups of 10 every month, and if you smoke, or I am obese, I help you, you help me, and we really, has nothing to do with alcohol, has to do with the control of risk factors. It just works. We have now 2-year follow-up, and this was all these studies are randomized, and you can see the tremendous impact that you have by working in community if you want to change your lifestyle. So I now begin to understand the psychiatrists when they talk about group therapy. You know, I never understood. My father was a psychiatrist, actually. But now I'm beginning to understand we adults need that. Somehow we work much better with other people. So this then leads to the question that these findings really led us to go to the brain. And was fascinating. What happened is one of the technologies we have used that I didn't present any data was MRI. And by fun, we look at the brain. We were looking at the arteries, and what we found is basically that in the brain there were so-called lacunal lesions here, which now we know is basically obstruction of the tiny arterioles on people who have risk factors, the 7 I mentioned, and they have not been treated. I presented this slide last year with only 6 papers. Now I want to add, there's much more that came out in this year, and I will be presenting to you 2 or 3 of them. But basically the concept is that we as cardiovascular specialists, if we think that controlling risk factors is more a stroke or no stroke, MI or not MI, we are wrong. Cognitive dysfunction is the problem here. So what we have seen is more lacunal lesions you see, worse is the cognitive function of these people. And this is actually what all these studies are showing. And the studies that I can add now, this is an analysis made, a very good meta-analysis in the Lancet. They say that 30% reduction in dementia would take place if people took care of the risk factors. We think it's much higher. We are now looking at this, as you will see in a moment. What is the denominator? How many people with degenerative brain disease or with acceleration of Alzheimer's have a vascular component? This is a study that was just published a few months ago, and that is showing, very interesting, vascular component is important in the speed by which Alzheimer's progress. 50% is deposit of amyloid in the vasculature, 50% appears to be what I'm saying. Hypertension has not been treated and so forth. This is what is being presented here. This is very, very dramatic and was published this week in JACC. And I must tell you, it's an incredible paper from Finland. Childhood. They look at children between age 6 and 18, those who had risk factors, and they didn't take care for 30 years. And then they look at cognitive function at middle age 40. So very well done study. You say children, risk factors? Sure. They have obesity, they go into high blood pressure, and then diabetes, and so forth. 20% of people in this country at age 10 are already obese or overweight. So they look at these people, and they look, well, those who were treated, those who were not, and then they did the method of standardized method now from Oxford of cognitive function. It is affected at age 40, age 50, in these people who at young age were not taken care of. And this is incredible. This is when 2 risk factors are not taken care. This is bad news from the cognitive point of view. This is 3 risk factors when they are not taken care. So this has led us to develop a European-American study, the Tan-Smith study, which I think is a study we are trying to understand all of this in a confined way. We state pathway 1 is to get 100 people who already have degenerative brain disease, and then we do all the technologies, not only cognitive function, but the appropriate imaging of the brain, and then we look at the large arteries. And the concept is that the risk factors play a role on both. But in how many of these people with degenerative brain disease, the problem are the risk factors we are mentioning, affecting also the large arteries. And then we have a fascinating study of over 2,000 people, near 3,000 people, families of Alzheimer's. And what we are doing is get them and to see exactly all the technologies I presented to you today, brain technology of imaging and technology also of the large arteries, and see if we can identify Alzheimer's many years before it appears by the technology that I am discussing with you. This is one aspect. And then the second pathway is the other way around. We get people who have calcification of the coronary arteries or an unusual 3D ultrasound, and then we go to the brain to see the other way around. What happens to the brain on people who already have subclinical disease in the large arteries? This is what we are doing. And finally, and I finish, is that all of this is a spin-off of the subclinical studies with 3D ultrasound, and some of them with calcification of the coronary arteries. We are getting so much interesting information. And now come children here. And this is fascinating. You see, these kids at age 3 to 6, they have the centers of the brain are not many and they do not connect well. And this is really very important because anything you tell a child at this age is captured and it is stored. That's why they learn languages so well. They are not mixed up. When they reach puberty, it's a problem because there are many more centers, many more connections, and whatever you tell your children what to do, they are very confused. And actually, in addition, there is the hormonal aspect that may play a role. So we took this project, and I presented some of this last year, actually, at this meeting. We presented the study in Colombia at 3 years of follow-up, and one study in Spain at 3 years of follow-up. Well, we now have 10 years of follow-up, and in addition, we have so many studies. We are dealing now with 50,000 children across the world. But let me tell you what we do. It's all randomized. So basically, we have, in Colombia, we started with 2,000 children, 1,070 hours of teaching health. How your body works, they have to understand that is the key. And then nutrition, exercise, and how to control your emotions, to learn to say no when in the future you are confronted with alcohol, drugs, and so forth. We did this in Colombia, 3 years of follow-up, the results. We all published all of this, fascinating. We did this in Spain, the same thing, including weight and exercise, much better than in the control group. And now the data is evolving in Colombia. At 10 years follow-up, still the intervention group is good. What is going to be at 20 years? We really don't know. This is, for example, I'm teaching these children in Madrid, and there are 50,000 children altogether. We are working in all these parts of the world. And actually, the study, why 50,000? Because we are now randomizing those children at age 10 that they are doing very well with intervention. We randomize them into reintervention, and we do not reintervene. And those who were controls, half we intervene for the first time at age 10, and half we do not. So what we are trying to do is to really learn something that I think is critical in health, is how we really educate people at a much younger age. And this has led us finally to use these strategies, and I go back to imaging, on the Harlem project. These are 600 families, and everything we are doing with the parents, with the grandparents, with the parents, and with the children that I just presented, although I focus basically in middle age on the imaging, is done in these families, and they are randomized, and we are trying to figure out how they do. In the children, we are measuring, we are looking at the genetics of the saliva in relation with behavior, all of them, 600. And in the adults, in the parents, age 20 to 35, we are looking at imaging. The disease starts at a much earlier age than what we thought. And I think this is something that we are now learning, going earlier and earlier in age. And it's amazing to me how the big enterprises, whether you call Google, whether you call IBM, whether you call Apple, they completely ignore children. So you can measure 1,000 variables in a 30-year-old. You are so damn late that I don't know what this is going to tell. I'm just telling you the fact that we are ignoring the most precious age if we want to have an impact on health, and this is our children, and particularly at that particular age. Well, I finish by saying to you that on the 12,000 people that I presented, what is fascinating, the data is so compatible with the 3 studies: prediction, feasibility, prevention, and the future. And here basically is to tell you that we started with children, we were out, and we went into the adults, as I presented, the family, Harlem, and now we are starting in Mexico, the Minister of Health, and in Peru. They want us to, all these projects to be carried out in these countries. So one thing that I actually learned is that in these projects, the young people are critical. Each of our projects have about 30 people, and about, I don't know, half of them are under the age of 35. We can motivate young people to participate in projects. It's not the health of the children. I'm talking now the investigators. We have a tremendous core of people who we could do so much, and we, as senior, we really have to pay attention. When we say this guy is passive, in a family, a father or a mother called me, my son, I don't know why you don't talk to, I said, let's put it in a project, and the success is incredible. So what I'm saying is we are in a society, those of us who have the opportunity to change it, be sure we pay attention to the young people, because whenever we think somebody is passive and somebody is in a different world, maybe we are in a different world, and we are not able to really pay attention to this. Well, I have 1 minute left, and I just presented to you what is global health from a personal point of view. These are projects that we all develop, and you can also develop yourselves. And then there's a more generic way. Well, the fact that we did this project scientifically driven, that is all are randomized, everything I presented to you. And the fact that this was published in good journals, and the fact that we are not politicians, made us to be called to really advise governments. And I was made the chairman, the co-chairman of this global health, the future role of the United States, global health and domestic health. So this committee evolved about a year ago, and we are going to Congress in the next few weeks, and then to see the president later. And what is interesting in this project is that we began with 164 priorities, and we ended up with 4, which I'm not going to describe to you. Life is a priority, and what I presented to you today, is not different. Let's go for subclinical disease and do the best we can to identify people, and let's focus on the young investigators. This, to me, should be the priorities, or at least the message that I would like to give to you today. Thank you very much for your attention.